Hello, I'm Supreme Court Chief Justice Maureen O'Connor. As you are well aware, our communities and our justice system are dealing with opiate addiction on a daily basis. This is a deadly situation that permeates all communities. Our courts, law enforcement, and treatment communities across the state are forming strategies to work together on this problem. We are making progress. However, we need the entire community to help us. Leaders of the business community, faith community, educators, medical professionals, and many others need to be involved. Please contact your local judge, prosecutor, sheriff, or other law enforcement leaders in your community and ask them how you or your organization can help us save lives that are at risk from opiates.
The greatest problem that we have working with alcoholics and addicts is our beliefs and our expectations of what they're able to do. This is what causes us the most frustration when we work with them. We say, well, can't they see what's happening to their families? And why don't they just quit? Well, it's really not that simple. And to understand addiction, we've got to go to the brain, and we have to understand one basic concept. And that is that the brain is chemical. There are no moving parts inside of my head. There's no hamster wheel. There's no little man with levers and pulleys and plugs. Now, I have billions of nerve cells with trillions of connections. And they work by molecules moving back and forth between the two cells, sending off a transmission, and then reabsorbing back into the cell. So very few molecules can pass through the blood-brain barrier, but certain ones do. Opiates, alcohol, THC, cocaine, methamphetamine, benzodiazepines, barbiturates, nitrates, and so on. What they have in common is the ability to cross through the blood-brain barrier into the brain, which then changes the functioning of the brain. It changes the way I think. You know, things like, what's a good idea and a bad idea? How late I should stay out? If you take your brain out of its normal chemical patterns, it's going to cost you. So we look at a brain scan, and now we're looking at the brain from 3 different levels. And the light area is high activity, and the low area and the darker areas are low activity. Okay? So we give this person crack cocaine on a Friday night. 10 days later, this is how the brain's functioning. 100 days later, after one crack cocaine use, this is how the brain's functioning. It's kind of like taking a 2x4 and whacking yourself in the head with it. You know, 2x4 is gone, so I must be okay. Well, let's look at a SPECT scan. Now, you read this by looking at shape and smoothness. So a healthy brain has a very smooth pattern. And we look at someone who's been using, it could be, any opiate, oxycodone, Vicodin, heroin. After 7 years, this is how the brain's starting to look. This is how it's functioning. After 25 years of use, this is what's happening. Now, there are people that are born with brains that look like this. We call them mentally ill. We say they have a psychiatric disorder. If you look at all the major psychiatric disorders, they're all due to unbalanced brain chemistry. So, unbalanced brain chemistry is a psychiatric disorder. Using alcohol and drugs causes unbalanced brain chemistry. So what does this tell us? It tells us that somebody who's using alcohol and drugs is not functioning any better than any psych patient that may be out there. So, you would never walk up to a schizophrenic and say, just stop hallucinating. Cut that out. But we go up to alcoholics and addicts all the time and say, just stop using, just stop doing that. And we expect a different result. So how do you get to be addicted? When you start using alcohol and drugs on a regular basis, your brain recognizes this as a new environment and begins to adapt to its new environment. So it's making changes in the brain to make you better at functioning with the drug in your system. One of the areas that's really being affected by this is the limbic system, which is your basic survival and drives. It's your animal brain. So this is going through changes. It's getting re-engineered. Eventually, you get enough change in this part of the brain to where the brain becomes confused, and it thinks it needs the drug the same way it needs food, water, and sex. And you can tell yourself, of course you don't need that. But that's like telling yourself, no, I never have to eat food again. So what this means, then, is that this is something that has to be treated, managed, and monitored over a person's lifetime. Because once that adaptation has occurred, it doesn't go away. It's permanent. It also means that as a chronic disease, periods of relapse are common. It's a common feature of addiction, but it's not inevitable. We can break the brain into two major parts. On top of your brainstem, about the size of your fist, is your animal brain. It houses your instincts and your basic survival drives. If you look at it, it's essentially a squirrel brain. Your squirrel brain wants what it wants when it wants it. It doesn't understand future, it doesn't understand consequences, it does not understand its behavior on all the little wooden creatures. But we have a second brain. We have a prefrontal cortex that does understand rationality, morality, planning, goal setting. These two brains are relatively independent. And so they are typically in disagreement with each other. My life as a civilized animal basically goes like this. I want, you can't have that. Addiction roots itself in the limbic system, in the squirrel brain. It has nothing to do with logic or rationality. What happens, though, is that the person has to deal with all the problems that is being caused by this loose squirrel. If someone starts using alcohol and drugs as an adolescent, it's going to mean two things. One is they're going to adapt to it 5 times faster than if that same person had started at age 21. It also means that they're not going to have a fully developed prefrontal cortex. That means this part of their brain that tells them not now, don't do that, wait for this, is very weak. The good news is once they stop using, this begins to catch up. But when you're trying to do treatment with someone with this kind of a brain, it's very difficult. Ask anybody who works with adolescents or ask anybody who has an adolescent. So the greatest problem we have working with alcoholics and addicts is our own beliefs and expectations. But it helps us if we start to understand that the addict is always doing the best he or she can. They don't need shame, they need treatment. Thank you.
Medication-assisted treatment is something that we're all talking about a lot nowadays. So when I talk about medication-assisted treatment for the use of, for use in patients with drug and alcohol problems, especially opiate problems, what medications am I talking about? I'm talking about two groups: opiate agonists, which are opiates, and opiate antagonists or blockers. The opiate agonists are buprenorphine and methadone. And opiate antagonists, naltrexone, is just a medication that blocks opiates out of the brain. When giving medications to a patient, be it agonists or antagonists, it's always essential to monitor that patient. Monitoring to be sure that a person has completed their intensive outpatient program, their aftercare program, is going to 3 or more 12-step meetings a week with a sponsor and a home group, is periodically getting tox testing, and periodically you're checking the State Pharmacy Board website to see how the patient is doing. As we look at opiate agonists or opiate antagonists as potential medications in any given patient to try to help them with their opiate addiction, what are the advantages and disadvantages of one over the other? Well, certainly right up front, one of the very clear advantages of an opiate agonist, buprenorphine or methadone, is that they're opiates. They make people feel better right away. They decrease cravings, they stop withdrawal. Patients like them because they feel better and they take them. There are some disadvantages of the agonists, though. It's hard to find them. There's not a lot of availability of buprenorphine and methadone in our communities, and there's even less availability of good providers of buprenorphine and methadone in our communities. So that's a major challenge. In addition, opiate agonists are very potent opiates, and so if a person's done well on them and now has decided to get off, it requires a good 6 to 12 months to taper them off very gradually. If you taper a patient too quickly off of buprenorphine or methadone, they will go into withdrawal. And when they go into withdrawal, they will get the cravings back, and therefore the risk of late relapses is substantially higher with opiate agonist therapy. They do have some differences, though. Buprenorphine has much less withdrawal associated with it. It has withdrawal, but much less withdrawal than methadone when you stop it. Buprenorphine is way, way, way less dangerous in overdose than methadone. And as a consequence, a physician can actually write a prescription for the buprenorphine for you. Whereas if you need methadone to treat your opiate addiction, you have to go to the methadone program every day and drink a 1-day's supply at the dosing window in front of the nurse because of that risk of overdose. On the other hand, buprenorphine is substantially more expensive than methadone, and it's harder to take. Buprenorphine is a sublingual medicine, which means it has to be absorbed by the mucous membrane under the tongue. So when you take your buprenorphine under your tongue, you have to hold it there for at least 5 minutes, maybe up to 20 minutes, in order to obtain an appropriate blood level. Whereas with methadone, you just snork it right down and swallow it and go on about your business. Anyone who's done well on an opiate agonist and then has done well tapering off the opiate agonist and now isn't on any medicine absolutely should be offered an opiate antagonist, naltrexone, for a 6 to 12 to 24 month period as sort of an insurance policy against those late relapses that we see when people come off of opiate agonist therapy. Speaking of the opiate antagonist, naltrexone, it's available in 2 forms, as I mentioned before, by mouth as a prescription pill and by a once-a-month injection. The oral naltrexone is 10 times cheaper than the naltrexone injections, so it's nice and inexpensive. It's easy to do. You just write a prescription. You don't have to have a center that can do the injections. The injectable naltrexone is more expensive, more logistically difficult to give to people, but way easier to monitor because you just give a person a shot once a month and don't worry about it anymore. And you don't have to worry about them taking the medicine every day. And they're about equal in terms of efficacy, in terms of how patients do when they're on them. Because of those changes in the brain, 80% of relapses take place in the first 6 months. So whatever you do to help a person get sober, you ought to absolutely do it full tilt for the first 6 months. There's no need to taper naltrexone. It's not an opiate. There's no dependence. There's no withdrawal. You can just stop it. And any prescriber can prescribe it. Anyone can, to any number of patients. There's no cap. There's no anything like that. So theoretically, naltrexone should be very available in our communities. So in summary, medication-assisted treatment for opiate addiction, state-of-the-art right now in Ohio. We have very reasonable agonist options and antagonist options. If either The antagonist, naltrexone, or either of the agonists, buprenorphine or methadone, are provided within the framework of a biopsychosocial spiritual recovery program, of a good recovery program. You can expect 40 to 60% sobriety rates or abstinence rates amongst patients. The duration of therapy should be a minimum of 24 months. The dose should be the lowest effective dose, as with everything. And every Ohioan with an opiate addiction who's willing to participate in drug and alcohol treatment should be on one of these 3 medications in order to help them as they struggle with this devastating disease. Thank you very much.
I've been a trial court judge for 31 years. I've watched the phenomena of specialized dockets over that course of time and talked to a lot of judges who encouraged me to get involved with a drug court. Never really saw the need to do that for a long period of time. Not until the opiate epidemic and pill epidemic reached our county a few years ago did I see there really was a need to do something different.
I think the opiate addiction has become an epidemic in our state and probably across the country. But I know as a municipal court judge, we're in the front lines of it. I'm seeing them before they become felons for the most part, and it is heart-wrenching. And when you finally get them in the appropriate treatment, on the appropriate medication, with the support system that they need, and they come back and they are working a job or maybe back in school and they've reunited with their family, there is no better feeling in the world. It makes you feel like, you know what I do makes a difference.
One of my favorites is about a gentleman who entered our program, used immediately, just didn't really seem to be interested. They sent him to the emergency room and he was admitted into ICU. And when he got out of the hospital and came back to drug court, within 3 weeks, we rated him an excellent. We call that our E-team. I received in the mail shortly after that an incredible letter from him. Your Honor, I am hoping this letter finds you well and in better spirits than when we last talked. When we had our last conversation, I could not help but to feel a sense of sadness and frustration in your voice over recent events in drug court. Do not despair. We drug addicts are a stubborn bunch. We need people like you in our lives, even though we do not know it. We need to see that there is someone out there who cares, someone who is willing to go that extra step, work that extra hour. How many lives are you required to save? I believe that saving one is enough. You were instrumental in saving my life and turning it around for the better. So from the depths of my heart, thank you.
Let's treat it together.
Let's treat it together.
Let's treat it together.
Let's treat it together.